Hello and welcome to the final session of our Global Population Health event. I'm Dirk Dougal. I'm a public health doctor, a senior consultant and programme director here at the King's Fund, and I lead much of our work on population health. I'm delighted to be joined today by a fantastic panel. So Dan Alton, Sohail Munshi, Anna Crisp, Edward Kononga, and we've got contributions from Don Berwick as well later on in the session. I'll ask our team to introduce themselves in a moment, but first, just a reminder that this part is pre-recorded, but that means that we still want questions from you. So do please submit your questions via Slido as well, and we will do our best to answer as many of them as possible in the live session later. You should be able to see a box next to the video, which is where you can submit your questions and also do actively take part in our poll throughout the session as well. We really want to hear from you. So a common theme when we work with health and care systems across UK is population health management and how that fits with population health. How can it be used to really create meaningful change? So I'd like to start by inviting our panel to introduce themselves and explain a little about how population health management has changed the way that you work for your population, and maybe how you work with partners. Were there any techniques that helped you through COVID-19, for example? So Edward, let's start with you.
Thanks, Decca. Just to quickly go through a brief introduction and some of the work we have done up here in the Northeast. So I'm Edward Kononga. I'm a public health consultant working across County Durham and Darlington Foundation Trust, Tees, Esk and Wear Valley Mental Health Foundation Trust, and also working with the North of England Commissioning Support Unit. The work that I'm going to talk about is what we did in one of our local authority areas, Durham County Council, in response to the COVID-19 threat. At that time, it was a threat. I mean, obviously now we know a lot more about the pandemic, but at the time, the Director of Public Health wanted us to identify people who would be more vulnerable, not only from the clinical side, but also social vulnerabilities. And we quickly realized that we had lots of information and data about these individuals, but in silos and perhaps structured by the specific issue that they had. So primary care would have all the medical information. The local authority, different departments had data on these individuals around social vulnerability, welfare support, and any social support that these individuals were having. And then we also knew that people like the fire brigade had a vulnerable patient list. We also knew that DWP had information. So we quickly came together and said, how do we come up with a way of understanding our population, understanding the complex interaction between clinical and social vulnerability, but more importantly, so that we can target and provide them with the right support. So that's the work that we did. It involved bringing together lots of different data, quickly agreeing the legal basis for sharing the data, creating an integrated data set, but also on the other side, having a combination of social care, public health, primary care, secondary care, colleagues coming together to say, right, once we've identified those individuals with multiple vulnerability, how do we make sure that we proactively target them with the right level of support? And the work is still ongoing. So we started that with adults. We're now beginning to think about the impact on children and young people. So we've got another exciting program where we are saying, thankfully, the clinical impact on children and young people from COVID-19 is not as great as in adults, but the indirect impacts are going to be intergenerational. So we're doing exactly the same exercise to say, what are the factors? What do we know about this? And more importantly, how do we come up with an understanding of multiple complex intersection for individuals so we've got a more integrated response? So in a nutshell, that's some of the work that we have done. And I think using the population health management approach helped us to have a structure, helped us to bring partners together, and more importantly, to move towards a single version of understanding complex vulnerability within our population.
Thank you very much. Clearly a lot to delve into there. People will be very interested in that notion of intersectionality your use of data across the multiple sectors, practically how they do it, and also the way that you're using it to actually predict and prevent issues in the future as well as reacting to now. Thank you very much. Dan, what about yourself?
Thanks very much, Durka. So I'm Dan Alton. I'm a GP in Berkshire in England, and I'm CCIO, Chief Clinical Information Officer and PHM Clinical Lead for Berkshire West CCG. And I'm also National PHM Clinical Advisor for NHS England and Improvement. And I think population health management really gives us a very powerful methodology for looking, as Edward mentioned, at our integrated data sets. And as time goes by, these are becoming more and more insightful. And we can take that data coupled with the expert analysis that our analyst teams can offer, and then really go out to our communities, take a sense check with our partners across health and social care in the voluntary sector, and crucially our patient groups, to really understand what that data means, to get under the skin, if you will, of what's happening out there in our populations, to different cohorts of our populations, what's happening within our communities. And when you start doing that, when you start coupling the data with local insight, patient experience, you begin to realize, I think, that what's affecting health outcomes is multifactorial. And in order to address these, particularly addressing the inequalities that COVID has potentially exacerbated, but certainly focus our attention on, understandably, in order to tackle these issues, you need a unified, integrated approach, looking at what partners over the extent of health and social care and the voluntary sector can offer to provide this holistic approach. And when you start doing that, when you start truly working in an integrated manner to address these holistic factors, including the wider determinants of health driving these inequalities and outcomes, you can really create a very powerful vehicle for transformational change and almost a cultural change, so that all partners and patient groups are on board, understanding what we need to do and giving us a starting point in order to do that. And COVID really has changed the landscape dramatically. It's laid inequalities bare. It's created many, many challenges, not just the effects of COVID-19 itself, but the wider effects, issues such as isolation within our communities, mental health presentations, the importance of proactive, preventative care. All of these have been put sharply in focus for us, but PHM offers a framework to tackle these challenges. And to end on a positive, I think this is a unique time for change and innovation. And our systems have really stood up and responded to the challenge with some fantastic innovative work. And we can now capitalize, springboard from that to change the way we do things longer term and significantly improve the health of our populations.
Thank you very much. So you've entered onto some of the key ingredients in terms of using PHM for the potential it holds for population health, the culture change, the transformation, the inequalities. Again, things that we will need and want to dive into through this session. Thank you. Sahel, what about yourself? An opportunity for you to introduce yourself and give some thoughts.
Thank you. I'm Sahel Munshi. I'm a GP in Manchester and also the interim Deputy Chief Executive of Manchester and Trafford local care organisations. And I think I should probably start by saying that I'm still a part-time GP, which is something I'm very proud of. It means that I've been a guest in the lives of my patients for the last few decades. And that's the thing that brings me forwards to the subject of public health and of integrated care. And it brings me into the other role of the local care organisation. And I think that's important to recognise and say. The other thing that I should also just reference is that one of the wonderful things about working in the City of Manchester is that we have benefited from devolution and the integration of adult social care in particular with health. And that brought us rapidly to wanting to seek one version of the truth, if you like, So we had different languages between GPs and social workers and community staff and voluntary and community workers. And what we've really done is used the public health management tools that Dan and Edward described so well to bring those professionals and clinicians together and to focus them on how they can make data-informed decisions, better decisions about our collective patients, residents, the people that we look after together. So for me, this is about how we enable those professionals to provide better care, and in particular to try and address the systemic health inequalities that we know exist in this country. And again, in Manchester, we have some of the worst population health outcomes in England. And so it is an absolutely burning platform for us. And this has been a massive enabling tool, I would say, to bring those partnerships together. And the simplest quick example I think I could probably give is that when COVID hit and we had to really rapidly establish how we were going to make sure that our vulnerable and shielded patients were getting the care that they needed, what we realized is that we had all of the relationships and all of the structures in place to have one conversation about those people. We were able to identify them, and we were able to work together to think about how we would address isolation, getting drugs to them, making sure that we were listening and hearing their needs and addressing them, that we were rapidly into things like community work and digital enablement for people who might have been digitally excluded. And all of those relationships were in place. We didn't have to come around a table to work out how we would look after those patients because we were already around that table. So that's probably all I'd say at this point about why I'm here and what I think the really exciting opportunities that lie ahead are.
Thank you very much. And I think what you've beautifully demonstrated and just what you've said is that whole role of however senior we are as system leaders, and I notice this in all the areas that are further ahead, it's that humility and that power dynamic to say, you know, it's not doing unto the population, but it's enabling the population and being that guest and learning and listening from others. Thank you. Anna, what about you?
So I think in Suffolk, COVID-19 has definitely strengthened the partnerships that were already there. I should say I am lucky to work in an area where strong partnerships already exist, and I do appreciate that that's not the same in all areas, and sometimes this can feel very difficult. However, because of some of that longer term partnership working, so for example, the SODA work that we'd done, we had a really good foundation that we could build on, which meant that we were able to put, you know, data flows in place, analytics in place, and most importantly, actual responses in place based on that data and analytics. And if you told me in March or April how quickly we would be able to do that, I don't think I would have believed you, but actually we were able to pull on people's skills and time from across the system, which people gave of incredibly generously. And we were able to sort of take some barriers away that had stood in our way before, and suddenly they were sort of removed. The information governance arrangements were clarified by the government, and that meant we could really press ahead. I think in terms of being surprised, I was surprised about the pace, and I was surprised about the scale of what we were able to achieve. And I think going into the second national lockdown again, we were able to use the data that we were already holding, plus additional data from NHS Digital, to again proactively reach out to people. And even though lockdown came in pretty quickly, we've already reached out to over 5,500 potentially vulnerable people in Suffolk, and we were able to do that very quickly from the data that we held. And I think that's an amazing achievement. The other thing which has been really interesting and a bit surprising to me more on the analytics front was being able to draw on the real skills of the multidisciplinary team. And in particular in Suffolk, we've had some really interesting conversations with our police colleagues who use a particular system which is designed and built to track networks. Now, usually they're trying to track networks of criminals, but networks is what this virus is all about. It's all about the network of cases and contacts, and which one of those contacts then become cases and their contacts, and on and on and on it goes into a huge kind of interlinked network. And so we've had some really interesting conversations with police colleagues about whether we could perhaps start to use that software in a COVID context, and we're following that up now with the supplier. So I think the thing that's been, I mean, obviously it's been a desperately difficult time, but people have really been creative and have been amazing in terms of solving problems, and that hasn't been a surprise, but it's been really, really heartwarming to see.
Thank you very much. So that's fantastic. We've had a snippet of thoughts from our panel. Now, without further ado, let's dive in a little bit more. So Dan, you talked about transformational change, and I agree with you. We did a piece of work on transformation a few years back, and it does feel like we are on the cusp of something really exciting. So really just to hear from you a little bit about what innovative ways of working have you experienced over the last 18 months that have enabled you to care better for your local population, that makes you feel so positive about the opportunity ahead, and also maybe some reflections about how to capitalize on those.
Absolutely. Well, as Sahel mentioned, getting the right people around the table is so important. And I wanted to give you an example, a very recent example of how this can be applied on the ground, so to speak. So we have locally to where I am based in Berkshire, we have population health management groups, boards. And these groups contain representatives from the primary care networks, from general practice, from our local authorities, our councils, but also analysts, patient representatives, representatives of patient groups, representatives of the acute trust, community trust. All partners are around this table to tackle problems. And what we found in common with many areas around the country over the last few months is that mental health presentations to general practice were increasing at a seemingly exponential rate. And our clinical directors, our primary care colleagues, came to this group and said, we feel we need to take a system-wide integrated approach to tackling the root causes of these increase in mental health presentations. So we went through a PHM methodology to try and identify what was happening. And in fact, the data and our analyst support backed up the fact that we were seeing an increase in presentations. But the crucial thing is these increase in presentations of mental health pathology were not affecting the population in a homogeneous way. Different cohorts of the population, different geographies, had an increase in the mental health presentations over and above other areas. And so we were beginning to, as I said earlier, get under the skin, try and really understand what's happening out there in our communities. So with the help of some qualitative work, going out to patient groups, having discussions with colleagues on the ground who are working within these communities every day, both in health, social care, and the voluntary sector, we began to realize that what was driving, certainly amongst a number of cohorts of our identified population, these increased presentations were not necessarily what we could count as medical pathology. They were housing issues, finance issues. In one particular PCN area, in particular, job issues, workforce issues. There was a lot of unemployment within that particular area for various reasons. So we decided what was needed wasn't necessarily a medicalization of these problems, but tackling them at the root cause. And so with the help of our local council and the significant support of partners across the board, we put in place an innovation to try and achieve this with mental health support workers going out into communities to promote good mental health, a one front door telephone number that residents can call and have a holistic assessment, not just looking at a particular problem that they would normally contact, for example, Citizens Advice with, presenting with an issue with finance. But when they do call this number, they can get support with financial issues, housing issues, workforce issues, forming a network to help support communities and communities support themselves to get through these difficult times. Now, this has been heavily advertised. We put 11,000 leaflets through doors. And I would say, just as an aside, we're looking at more environmentally friendly ways to advertise. And we have put lots of information on surgery websites, in surgery waiting rooms, on the council website. So it's a community integrated approach, having recognized a problem to try and support our communities to tackle the root causes of these health outcomes we're seeing. And I would say as a final point that for a GP like myself working on the ground, seeing patients with this presentation and noticing this increase, this is really inspirational. The system has come together to holistically tackle the wider determinants of health. And that really makes me feel when I can offer these services to patients on the ground, it makes me feel that I'm not alone in general practice tackling these problems. The system has a common vision, and population health management and the principles and scientific methodology being followed to get to this understanding of the data and tailored solutions and innovations has facilitated that feeling at the end of the day.
Thank you very much. And I think that chimes with the data, doesn't it, in terms of the wider determinants and the important role for an individual or populations that it plays, even compared to healthcare, just that massive importance in dealing with those. So Edward, going a bit into COVID, so I know we've talked, Dan's talked about mental health and COVID and some of that great work. What about you? How important was the role of data and digital when Durham Council partnered with the North of England Commissioning Support Unit to do population health management to support COVID response and recovery?
Thanks, Decca. When we started this work in Durham, this was towards the end of January, where we were seeing those reports daily on the news of what was happening in China and what was happening in northern Italy. And we knew that at some point it would arrive in the UK, and already we were beginning to see cases down south. And what we were trying to do was to really use the data and the information we have to identify those people with the risk factors that those reports were telling us. So we all knew that people with underlying long-term conditions were having severe disease, were ending up being hospitalized, and sadly were ending up losing their lives. And we knew that across our system, we could identify who those people were. And we knew that with the benefit of primary care being the universal health service that reaches out to most people, then we will utilize that, but also being mindful that the groups that are not really accessing primary care or not known to primary care perhaps fall in those other vulnerable people as well. So who else knows about them? So who knows about the people who are homeless? Who knows about people who've got substance misuse addictions? Who knows about gypsy, Roma, and travelers? Who knows about asylum seekers? Those groups that we knew that relying only on primary care data, we would miss out. And we know pre-COVID that these people or these population groups didn't have the right or good outcomes. So we quickly identified that, well, we collectively know our population, but perhaps we know bits of each individual. And if we brought that together, it would help us to understand our population better. And we thought that it would help us at 3 levels. We thought it would help us, and it did help us in terms of managing, identifying the people with the greatest need and making sure that we can identify who they are and we provide an integrated response. The second level was then, how do we utilize this to start planning for cohorts of patients? So how many people are we talking about? And actually, how are they distributed across our county? And how do we ensure that we utilize all the different assets to provide them with the support? So we found that the information anonymized, at that point, you don't need to know who the individual is, would be very helpful for planning, for coordination, and also for continuing to improve the services in response to COVID. And then the third point was more from a surveillance point of view. How do we make sure that we continue to keep an eye on those populations, make sure that they receive the right levels of interventions, and what is that telling us from an outcomes point of view? And we found we couldn't do that without integrating the data. We could have a partial understanding on an issue-specific point of view, but actually we would be missing out on what is happening in people's lives. So for instance, we could, had we not integrated the data, we could congratulate ourselves that we've identified the shielded population and they are now shielding, but actually those people might actually be having adverse outcomes because there's no continuity in their welfare or other support that they would have been receiving. So bringing that data together allowed us to start looking at the individual in a holistic way and coordinate the activities that were focused on preventing the risk of picking up COVID-19, but also whilst you are utilizing those preventative measures, how do we address the indirect impact of encouraging people to comply with the preventative measures? And how do we support those people who, for various reasons, might not be able to put in place alternative arrangements to ensure continuity of care, continuity of welfare support, continuity of social interactions? So we couldn't do that without bringing the data together. And we strongly believe that this has given us the opportunity of using a framework that will help us with all the pre-COVID issues and also the COVID legacy. So we now know that we can identify people who have had COVID-19. We're developing a program to look at the long COVID support, which is not just medical, but also which takes into account all the assets that we have. We now know that we can identify for multiple vulnerabilities, the interaction between clinical and social vulnerabilities. But more importantly, we also know that you can utilize that approach for universal messages and for encouraging people to participate in preventative measures that will help them to improve their health and well-being. And we can identify the health inequalities and make sure that we adopt that proportionate universalistic approach that provides support for the population, but also responds in a proportionate way to the level of need. So we feel we are in a very good position now, having done, if you like, a proof of concept. We are now looking at, right, well, having done all this work, what are the other wicked issues that we face in our communities that lend themselves to an approach where we can bring the data together, but more importantly, intervene in people's lives and make the difference that we are all passionate about.
Thank you very much. And as you're speaking, that sophisticated approach that you're talking about in terms of understanding and reaching to your population, it reminds me of when I was looking after screening and vaccination programs. And a live question at the moment is often with primary care colleagues saying, how do we even think about potential vaccination programs? What you've just described there, I think, is highly relevant, and the approach that would be the more effective one to take. Thank you. Let's turn to inequalities. I mean, clearly something that has been highlighted as a major issue that was there anyway, but worsened, widened, and a spotlight shone on, which is inequalities over certainly the last year. Suhail, how has using a population health management approach enabled you to understand and address health inequalities?
Yes, absolutely. So we've heard some really good examples of using data and public health management to bring primary care closer to other providers to address social determinants of health. And I completely agree that that is the vehicle to get into addressing inequalities across our populations. So what I'd like to do just for a couple of minutes is to give a really simple, real example of a journey of how a primary care network that I was involved with moved to using a public health management approach in a very real way. Because hopefully some of those examples will chime with people in their everyday working lives. So if I think about one of the networks in North Manchester, a very, very deprived part of Manchester, the GPs there, prior to having a public health management approach, were meeting as a cluster of practices to talk about traditional health-related activity. And they'd identified that in their network, referrals to musculoskeletal services and orthopedics were particularly high, much higher than the other networks. And they were looking at it in a pretty conventional health way to say, what can we do? And why is this an issue? And this is approximately about 18 months ago, so it predates the sort of first contact physiotherapy offer that really helpfully then came from NHS England. At the same time, our communities and our neighbourhood teams were having a live conversation about what they felt the particular issues in that community were. And they'd identified a really strong theme around people contacting Citizens Advice and other support networks around falling out of health and about needing support with that. And so what we did is we brought those people together with council colleagues and decided to apply a formal public health management approach to look at the data. And what we were able to do from that is identify that actually we had a cohort of patients, 50 to 64 years old, who were predominantly from a BME background, who were in employment and were falling out of employment, and a significant number of them were having musculoskeletal issues. And because of the long waits for physiotherapy and access to services, that period of waiting, which was around 10 to 12 weeks, was unfortunately long enough for them to fall out of work and not be supported, that they weren't returning back to the employment arena. And so whilst, and this builds on Edward's comments earlier about different professionals know about different cohorts, but often what happens is nobody knows about a particular theme because we've not brought the data and the intelligence together. And what we realized is that we had a really specific theme about people from a BME background with MSK problems. And we were able to address that both from a health perspective by giving them direct access to physiotherapy at the very onset of the condition, something that we've now built into a first contact physiotherapy offer, and also from a sort of social and support and employment support offer. So we built our social prescribing networks around this cohort to make sure they were getting very early intervention and employment support. And what we've been able to demonstrate over the last 15 months is that significantly reduced the number of people who are falling out of work. And I think we all recognize that keeping people in employment, both for the social and psychological and status benefits, and also for the financial benefits, is actually the biggest single positive thing we can do to maintain their health and well-being. And that was just such a massive enabler. And what that's enabled us to do is to share that with the other networks and essentially make the case for public health management across all of the networks in Manchester and Trafford.
That's fantastic. Thank you. So that leads me really beautifully onto my question to Dan. So we've heard some fantastic thoughts and examples about good practice. How evenly spread is that across the country? What could care providers do differently, better to understand and tackle health inequalities?
Yeah, so I think different parts of the system are at different stages on this journey, but I think there is a realization, and I would say a national realization, that this is going to be a necessary methodology for tackling health inequalities. We have done things a particular way for many decades, and inequalities are now, due to the COVID pandemic, realized to be something we really need to focus on. And PHM methodology allows us a framework to begin to consider these inequalities and do something about it. And the environment, the data sharing environment, the infrastructure of shared care records, joined up data sources across the country, those environments are being created within ICSs and at places and at neighborhoods to begin to kickstart this methodology. So when you think about the way we have done things, and there are many, many advantages in this, but as Sahel mentioned, certain cohorts, certain individuals may slip through the net. And to understand the reasons why this happens, you need to understand, first of all, who is slipping through the net by looking at your data sources and getting your analyst support to be able to understand what is happening, and then go out to your communities to understand the reasons for this. So for example, to take this as a practical real-life example that we see across the country. If you have two patients with type 2 diabetes, both, for example, in their 60s, one of them may have a poor outcome compared to the other. And when you start looking at the reasons for that, and you've identified a cohort of the population with type 2 diabetes with this poor outcome, or the individuals within that cohort, you begin to understand some possible reasons why. So if you have type 2 diabetes, but you are also working 2 jobs, 5 days a week, and you also have financial worries and can't take time off work, and you also don't speak English as your first language, so you may struggle to understand both the communication inviting you to your annual diabetes check with your diabetes nurse specialist at your GP surgery, or you may not understand the diabetes education offered to you at that time due to language barriers and a whole host of other factors, then you probably won't actually attend your appointment because you can't get the time off work. Or if you do, you might not have the maximum benefit from that. And so what's happening to those patients? Well, historically, for those in the audience familiar with general practice in the UK, we would exception report them for QOF, i.e. we'll say they haven't quite met our requirements for our outcomes, so we're going to exclude them because they haven't turned up, they haven't responded to the invites. But what population health management methodology would offer for that individual, we would identify them as somebody who needs an alternative, perhaps more nuanced approach, and we would tailor what we offer in order to meet their needs. And to do that, we need to understand what it is to a certain extent to be them, what factors have led to this health outcome. Now, had we not done anything about that patient, they would possibly develop complications of their diabetes at a younger age, and the morbidity and mortality associated with it would be a significant and at a significantly younger age. And we find that when we look at health outcomes across our area, when you are living in deprived areas, you are unfortunately likely to pass away at a younger age and develop complications of long-term conditions at a younger age. So in order to reverse that, we need to start right at the beginning, matching our offering, what we provide patients with what they actually need, understanding those wider determinants of health. And PHM methodology allows that. So I would say to providers, go through the process, look at your data, look at what you have, consider things, stop and consider how we deliver services, and try and provide a more nuanced, tailored approach. And we're getting increasingly across the country lots and lots of evidence, stronger evidence base that this is a good way of doing things. So do a bit of thinking, stop, think, and consider how you can do things differently.
Thank you. Coming back to you, Suhail, then, to almost ask a similar question. So how does that compare with your approach? Is there anything you'd want to add to that in terms of how you use data to work with partners to understand and care differently for the population? Maybe advocate, to use the data to advocate, like Montefiore example shows. I don't know if there's anything else to add from your perspective of that.
Yeah, I think, so I completely agree with what Dan has just told us. I suppose what I would try to do is to translate it into my experience of what's happened on the ground. And I'd just like to bring in the sort of patient perspective, if I could, for a second. So one of the things that I discovered fairly early on is that some professionals were saying, how will patients feel about us working together, talking about them, meeting about them, sharing data about them? And actually, in almost all circumstances, what we discovered is that patients assume that we already work together, share data, and act in their best interests. Most people have probably, slightly depressingly, a view that health and social care data is shared and integrated, and they don't think about data sharing because they've already assumed that these relationships exist and that people are working together in the best interests of them. So I think that's worth noting, that it's something that we need to address head on, and certainly the data sharing aspects of these is, I think, work that we continue to need to progress nationally. The other thing I would say about the sort of partnership working influence of this is that what we've done in Manchester is we've sort of built on our community relationships and tried to formalise them. So what we initially did is we brought services together. So we brought health and social care and community services, the voluntary sector, faith, housing, etc., etc. We brought them together in the same space and built relationships. And then we started to have discussions that were PHM focused and led. And we ended up creating what we call, in a very northern way, MAMS meetings, which actually stands for multi-agency meetings. And we talk about families as well as individual patients at those meetings. And what I would say the learning from that is that when we describe this to communities and people outside of our professional silos, the main feedback we got is, that sounds fantastic. We did actually think that was happening anyway, but it's also very complicated. How do we feed into this? How do we feed into the partnership working that is the result of this work? And so for me, care navigation is a really, really important piece of learning that came out of that. So that in Manchester, if you're a librarian and you come across a lonely, isolated old person, you have one single point of contact, the care navigator, to feed that concern into. If you are from fire and rescue and you have a concern, you feed it to the same point of contact. If you're within the system, if you like, and you're not sure whether you need a community service or a district nurse or a GP or some social prescribing type activity, and somebody just needs finance advice, again, it's the same point of contact. And what we're doing is we are trying to simplify our health and care pathways by making it the responsibility of one navigator. And by doing that, we can pick up a conversation in a community, let's say in a library, and we can land it either in a social prescribing world, or a GP practices multidisciplinary team meeting, or a multi-agency MAMS meeting, or it might be that we can take it straight to the district nurse or the community services because it's a particular identified health need. So there's something about moving ourselves from being different siloed service-based organisations into genuinely being a neighbourhood-led organisation. And I think that's where the public health management work needs to take us and enable us to get there. So my overriding point, I think, is we need to think about how we make the decisions and the act on the data that we're receiving, and make sure that we are involving patients and residents in what comes out of that. Because if we don't involve them in the co-production of these pathways, we will still end up in our own silos with patients falling outside of them.
Thank you. And I'm hearing the voice of the voluntary sector, who I've been working with over the last few weeks, saying the opportunity for transformation may actually be turning the power dynamic on its head and not even involving, but being led by those people. And I'm thinking of the Wigan model, which really was quite exemplary in this space, and others. So NUCA as another. Thank you. Anna, a quick word from you in terms of, I don't know if there's anything you wanted to build on that, particularly in terms of your experience working to link data at Suffolk County Council.
So our experience at Suffolk County Council and with our wider health and local authority partners in Suffolk in terms of linking data has been really interesting. It's something we've been working on for about 5 years. We have an arrangement in place called the Suffolk Office for Data Analytics, and that's made up of the County Council, the 5 district and borough councils, the Suffolk Constabulary, so the police, and the 2 CCGs, clinical commissioning groups, which are health commissioning bodies which cover most of Suffolk. We've been working with that group of partners for about 5 years, looking at 3 key areas really. So IT, what are the technology and systems that are available to us? IG, so information governance, what's our legal and safe basis for sharing information. And then finally, analytics. So if you've got the systems and you've got the legal permissions, then what can you actually tell from the data? During COVID, we were able to put that sort of preparatory work into really good practice, actually. So we worked with the SODA partners to bring together over 40 different data sets, which between them cover a whole range of information about health, about social care, but also, really importantly, about the wider determinants of health. Our aim with the work was to try and understand different aspects of vulnerability in the context of the COVID pandemic. So we looked at indicators that might show clinical vulnerability, we looked at indicators that might show financial vulnerability, and we looked at indicators that might show social aspects of vulnerability. The sort of data sets that we used included information about people's ages, whether they lived alone, whether they were clinically extremely vulnerable, whether they were social care customers, be that for adults or for children and families, whether they were children in receipt of free school meals, people on the housing waiting list and in receipt of housing benefit, and also wider indicators such as whether people had a frailty alarm or were getting help with their bin collection every week, which is an indicator that they can't manage sort of physical tasks very well. We managed to link all that data, so we've got a data set of 140,000 different individuals through those data sets, and we were able to use that with all of our partners to look at those different aspects of vulnerability and reach out and proactively put things in place to support people.
Okay, so that brings us to the end of the pre-recorded section of this session. Thank you to all our fabulous speakers for all your input so far. We're going to now take a look at some of the questions that you've been submitting on Slido. Good afternoon, everybody. We're now joining you live, and I'm delighted to be joined by a blended panel of international and UK colleagues. Some panel members you've met already, so Dan, Anna and Edward. And we're lucky to be joined by Professor Don Berwick, who is the President Emeritus and Senior Fellow at the Institute of Healthcare Improvement, and also an International Visiting Fellow at the King's Fund, somebody who's been supporting our work for a very long time. So thank you for joining us, Don. So this session is our opportunity to really bring together all the threads from the fantastic discussions today and think about innovation and population health. We'll come to your questions in a tiny bit, but first let's start by asking Don two questions. So Don, what would you say are the greatest achievements so far from the implementation of population health approaches internationally? And how do you think that health and social care systems can build from all the lessons learned from COVID so far to improve population health?
I have the lucky opportunity to see lots of examples around the world of systems that are trying to focus on the needs of populations as well as individuals. In the United States, our best examples are probably the old-style health maintenance organizations. These are consolidated systems paid on a capitated basis for care of populations that are thoroughly enrolled for them in their care, so they know their population. The classic example is Kaiser Permanente, from which the National Health Service has taken a lot of lessons. They're able to execute pretty bold changes in care without worrying about which pocket the money's coming from. My test case for a really integrated population view is whether hospitals want to be empty or full. If the payment system and the ecology and the culture is such that hospitals are seeking to maintain their heads in beds, then the system's not integrated. When you observe a system that's trying to figure out how to move from hospital-centric to home as the hub, then you know you've got something. Kaiser Permanente is a good example. There are other national efforts underway. Actually, this very morning, I was on a call with the country of Singapore, which is trying very hard now to figure out how to move from essentially a hospital-centric view to a population-based view. It's very difficult, but countries of that size, 5 or 6 million, are able to think really much more clearly and broadly about how to move to a population-based care. The key is empanelment, enrollment, and identification with the care of the population. And I've got to say, Dirk, I'm pretty excited about what's going on in NHSI right now. I mean, the concept, the conceptual frame of moving toward IHS's integrated health systems is an idea that really has merit. And in the video that I observed this morning, testimony from some of the integrated health systems around the country, you get the feeling of, I get the feeling of a tremendous amount of possibility, real promise here. So I'm pretty excited. For COVID, well, it's unfrozen us. I mean, we've talked for decades about moving care into the virtual space where people don't have to travel and you can leverage the expertise of clinicians across vast geographic swaths. We're doing it now. And I think the whole dislocation of this tragic and unwelcome pandemic, but the dislocation that's led us to actually make virtual care a reality, truly important. I think we're learning more about the importance of strengthening public health systems. And I see the public health system is completely continuous with the care system when it's properly designed. For example, in England, the general practice system is and ought to be a component of a very robust system for maintaining and improving the health of the public. The last thing I'll say about change is the concepts of co-design and co-production with communities matters a lot. I'm not sure where COVID has brought us in that, but we now understand that unless the patients' communities are partners in dealing with a pandemic, we're lost. This is not something the healthcare system can deliver to communities. It's something we do with communities to control or get rid of this horrible pandemic. That's the way we need to think in the integrated system world. So I hope that's at least somewhat responsive to your question, Dirk. I'm happy to talk more about it as the panel proceeds.
Thank you, Don. And I think it will be reassuring to colleagues across the UK, because I think quite often when you're actually in the midst of doing all these changes and trying to bring across improvements, you get caught in the challenges and frustrated. But actually hearing you saying, looking at it from another lens, it's great work. I think it will be really reassuring.
Let me just say, it's superb work. I'm a little bit like an uncle that gets to visit their nephew every few years, and you show up and say, "Oh my God, how much you've grown." That's how I feel about the progress in NHS. I know how the troubles are there. I understand how difficult it feels and how small some of the gains feel. But as a friendly and outside observer, I'll tell you, you're making not small steps, giant steps, and I'm very, very hopeful.
Thank you. And that notion of co-production, I think colleagues on the panel will want to come to. Public health being absolutely critical in all of this, I think is something we all feel passionate about. So colleagues on the panel, I don't know if there's anything you wanted to build in terms of what Don said before we jump into some of the audience questions.
Okay. I would just say thank you, Don, because it's really encouraging to get some feedback, but certainly from an international perspective, that we are making progress. It can feel very slow on the ground. You can feel like you're almost dragging yourself through one challenge after another, and COVID has accelerated our innovation, so there have been some positives, but it can feel really a little bit challenging at times. But I suppose your perspective of coming from outside, from an international perspective, and seeing how we are innovating, how we are improving, that's really very kind of you to say, and thank you.
If I could say one more word about that, Dan. So listen to the video that I just saw, the pre-recorded testimony from IHS, which I think your audience has just seen as well. As you listen to that, Lancashire and South Cumbria and Dorset's integrated healthcare system and the Surrey Heartlands group, what you hear is what is absolutely essential, which is a sense of strategy. In each case, you had people testifying to basically the existence of strategy at Lancashire and South Cumbria, the addressing digital inclusion, for example, strategically across a population. At Dorset, a unified approach to inequality and closing those gaps. In Surrey Heartlands, you hear this. I think the term they use is proactive insights about the population, not waiting to be reactive. You have to be integrated to do that. So this to me is testimony to the progress that you're making and beginning to think in population terms. It's quite real, and it is really quite rare. So I hope you understand how important this work is.
Thank you. And actually delving straight into that, it's a theme that's been coming up in pretty much all of our questions today, but certainly for this session. So I think let's address that head on. There's a real sense of optimism and fear about the link between data, technology, and health inequalities. So the notion of actually inadvertently, we don't want technology to be widening health inequality, and yet it can be used to address it. So Anna, I know you've been doing some work locally in terms of an ethics framework. And then Edward, I know you were talking about resources being released for targeting support. So should we ask Anna and then Edward for your thoughts about that?
Thank you, Durka. Yes, it's a really important issue, and it feels like a very novel issue, doesn't it? We haven't had to grapple with this before we had, artificial intelligence and big data. We weren't in a position to make use of that. We've been thinking quite a lot about it in the context of Suffolk County Council. So I work slightly outside the NHS, but I work with local authorities using data from housing departments, for example, and also data from the police, which starts to get, really quite interesting in terms of what data you're sharing and how your population feel about that. Is that acceptable? And we don't have any really smart answers, but we have recognised the fact that we need to be explicit about asking those questions. So we've been putting together, and it's not quite finished yet, but we're working on it, what we're calling an ethical data stewardship charter, something like that, which will set out a number of key principles that we need to hold ourselves to as an organisation of Suffolk County Council, and say, does it pass all of these tests? Have we been transparent? Have we thought about participation? You've raised the issue about co-production already, and I think that's really important in this field. Have we got the right oversight? Is it fair? Who does this benefit? All of those things, and we're working through a charter which will, we hope, allow us to apply those tests kind of consistently and satisfy ourselves that what we're doing is the right thing. And just in case anyone on the conference is interested, I sort of came to this through some AI work that we've done with the University of Essex over the last couple of years about actually children's social care. And there's an interesting literature in the children's social care field on exactly that issue and how far you should act on what your data tells you. And if anyone else is interested, you might not be aware of it within health, so have a look at that. It's international as well, some really interesting things from New Zealand and from the States. Thanks, Durka.
Thank you. Edward.
Thanks, Durka. I think the issue around digital innovation is one that we all embrace. And I think throughout the pandemic, we have seen the benefits of being able to connect, of being able to do different things through digital advancements. But I think we should also recognize that access to digital resources is not uniformly distributed. And if we are not very careful, we will have communities left behind who cannot access for various reasons. However, I think if we're very careful, we can design the system in such a way that the resources and the capacity that we are releasing by doing things digitally are then redirected to provide support for those people who cannot access for various reasons. And there are a number of examples that we are doing, certainly in our patch in Durham. So in the hospital trust where I work, we are analyzing the patients who do not attend for appointments to really get to understand, and that's where population health management would help us to understand their circumstances, but also more importantly, to ensure that their lack of access to digital infrastructure does not inhibit or compromise the care or the continuity of care on their behalf. So I think it's one we need to embrace, but we need to make sure that the efficiencies that we gain and the resources that we release are then targeted at those people who cannot utilize or who cannot make the benefit of these advancements. So I'm sure there are numerous examples up and down the country. I think we need to make sure that as we move forward, we do not leave some communities behind. And the data and the population health management approaches can help us to proactively look at who are those people likely to be. So we are not reacting all the time, but we are actually, as we redesign pathways, putting in place provision from a healthcare point of view, from a continuity of welfare support point of view, to ensure that these communities and individuals are not left behind. Thanks, Durka.
Thank you. So it sounds like an almost unanimous call from our panel and actually from people who are here. I mean, I'm reading between the lines in terms of your questions. It's going to be incumbent upon all of us to make sure that health inequalities is a core focus in all our population health approach, whatever we do. So there's something about, as Anna says, really thinking through how we can avoid widening health inequalities, think about the ethics and framework, maybe redefine what digital poverty now looks like. and then also proactively addressing. Thank you. Moving on to that notion of resources then. So Don, I'll come to you if I may. So a question that comes up a lot is, to do this right, we need to resource it well. We need to maybe go beyond the 4-yearly commissioning cycle or the kind of current siloed funding. What are your thoughts about international models that might work for this?
The key to me is to think about unified budgets, population-based financing. What I think the term you sometimes use is control totals or something like that. I can't remember the expression you use in England, but there may well be enough money around. It's just in the wrong places. And so by moving upward and consolidating financing of health and social care in a single pot, which is the way to go, you may discover that there are resources you can move from one place to another. You also can harvest improvements. For example, one of the best effects of improving population health care management is a reduction in hospital use. Hospital use is very expensive, but by moving care to home, making home the hub, offering supports to people where they live, you actually should be able to harvest back some money that then can be reinvested, but only reinvested if there's a single budgeting view. The second idea, by the way, about financing has to do with what my colleague Paul Batalnik calls abundance. You know, I think part of the beauty of really integrated care is that it gives you a chance to enlist the energies, resources, the wisdom of patients, families, and communities. They become part of the care. And it's as if you hit oil. You discover this wealth of energy for people to actually take care of themselves. In England, for example, you have somewhat pioneered the hospital at home concept. That's a very, very good idea, but it also maximizes the chances that people actually do things for themselves. And that is it's sort of increasing the budget in a weird way, because you're now making the community part of the workforce in a way they very much want to. Those are two thoughts about the financing side.
Thank you. And Dan, you've got the dual role of locally the work that you do, but also the work you're doing nationally. So shall we come to you for your thoughts about things that you're seeing or thoughts that you have?
So I think one thing that it's probably worth mentioning is looking at how we can achieve across the board the kind of advances that have been presented here today across the whole country, rather than just in the very mature systems. And I think you can look at different ways of resourcing this, but almost more important than that is winning hearts and minds. And this can be a challenge, at least to start with, before you gain momentum within areas. And one thing I would say that works quite well, especially when you're facing challenges back from clinical colleagues and others in the system saying, look, we can barely cope with the work we have at the moment. We don't have time for any of this kind of new stuff. Is to say, okay, well, let's take a moment to think about what has been frustrating you, and going on to patient discussions, bring in some patients, bring in patient representation, patient groups, and say, what has been frustrating you over the last few weeks? And then you often get the things that those of you who work in the NHS often hear in the coffee room: I don't have enough time. There's too much work to do. Or from patients, I can't get an appointment with my GP. And then you've got a starting point. Then you can say, okay, well, why might that be? And you get past the kind of magic money tree side of things. There's no unlimited budget to fix these problems. We can't magic up new GPs, but what we can do is change the way we do things. So take a population health management approach to look at what our population needs and deliver that in a more streamlined, integrated manner. Now, that may involve lots and lots of innovations that we can talk about, looking at proactive care, rationalizing long-term condition care, working much better with the voluntary sector and colleagues in social care, so that the right people address the actual need. but at least you're moving forward. And then when you start moving forward, you're looking at your data, you're looking at doing things differently, you're building up a gradual social movement of innovation. Think your way out of these challenges we're facing, and then it starts building like a snowball. So I would say that we do certainly need some ideas about how we can lever commissioning strategies, payment strategies to work in all the different ways we've heard about today. But in a way, we can't forget to engage our colleagues, clinicians, managers on the ground, patient groups, absolutely crucial, as Don was saying. When they become part of the solution, it's like you've hit oil. You can really support self-care. And then when you begin to build that consensus, you're onto a winner. So let's not forget that on-the-ground consensus and winning hearts and minds.
Lovely, thank you. I can't echo that enough, because for systems leadership and complex systems, that's the way that you need to work, that social movement, that organic, that kind of hearts and minds, isn't it, as well as data. Anna, quite often we hear that police are a group that actually are so important for this, but people don't know how to engage with police necessarily. You're doing exciting work with the local police and local government about resourcing. I don't know if you want to say a bit more.
Yeah, so we've been doing work in Suffolk for the last 4 years now, trying to bring together, quite a big partnership of organisations. So that it's quite a little bit complicated, but basically we've got 5 local authorities and a county council, which is a different sort of local authority, and the police and our local NHS commissioning groups. And we all came together about 4 years ago to look more comprehensively and systematically at how we could use data to provide a better service for our residents. And I think it comes back to what Dan said about, you have to just start somewhere. Everyone in that partnership invested what was, in organisational terms, quite a small amount of money, and that includes the police. So it wasn't a sort of huge stumbling block. I mean, it was a little bit of a stumbling block, they had to agree, but it wasn't an enormous problem for everyone around the table to find a relatively small amount of money. And that was enough to get us going with our work around IG and about information systems and security, and then about data, and we've tackled those 3 things alongside. And my police colleagues have been, absolutely amazing in that. And very recently, we've been exploring a system that the police use to track criminal networks, and whether it actually has an application for us in tracking networks of cases and contexts in the context of COVID. So, we would never have thought of asking the police about that, quite genuinely. But because we've been working alongside each other for a few years, actually, that you make those relationships, and the money is part of the picture. But I think what Dan and Don said is right. When it starts to really flow is when you've got the relationships there, and that costs time, and you need to be committed, but it doesn't necessarily cost an enormous amount of money, and then you can build on everybody's great ideas and good practice.
Lovely, thank you. And I think there's something equally key in there, in what you just said about, we may not always understand the value of what another partner can bring, but have that conversation, explore, and I think you'll be surprised. So in Oldham, we've been doing work for the last 2 years, and it's just been amazing, all the contributions, including police. So fabulous, thank you. Edward, people sometimes talk about a place-based currency, a place pound. I know you're looking at this in, for example, Durham. Do you want to tell us a bit about your thoughts?
Yeah, thanks, Decca. I think we could all do with more resources, couldn't we? But I think one of the challenges is, how do we make the most of the resources that we've got coming into an area? And how do we go beyond the perverse incentives that are in the system? I think Don mentioned some of the perverse incentives regarding how hospital activity is paid for. I think that's only one example. I think there's quite a wide range of perverse incentives that, if systems are not very careful, it puts you one organization against the other. And when you can walk away and think that the organization has won, sadly, in most of those cases, the local people are the ones who have lost. So how do we ensure that we collectively look at the resources coming into the place? And by resources, I'm not just meaning the big budgets. I'm also thinking about the staff we have. I'm also thinking about all the other assets
and the community power and potential that we have within that area. How do we align it all together so that we all paddling in the same direction and improve outcomes for our local population? So in my previous role, I was Director of Public Health for 2 local authorities in the Northeast, and they came together and started talking about the South Tees Pound. And it's amazing when we mapped the amount of resources coming into the area through health, through local authority, through grants, voluntary community sector, police, fire and rescue. It was enormous. And actually, we started then thinking about how do we ensure that we still support organizations to deliver their core business, but also at the same time maximizing where there are opportunities for us to join forces to improve outcomes for the local population. So it's all about thinking about the resources that are coming into the place. How do we align those resources to deal with the local challenges? And how do we, in most cases, try and avoid organizations fighting against each other? Because we know that whilst an organization might think they've been successful over another, usually, in most cases, is the local people who do not benefit from that. So yes, they might end up receiving an excellent police service, but actually from all we know about the wider determinants and the intersectionality between the different factors, what people would want is a joined up, coordinated offer that deals with, in this instance, crime issues, but also with health issues, that deals with behavior issues, but also supports families and builds on the community assets that are in that place. So I think thinking about that currency and the totality of resources in the local area is a great way of pulling communities together and thinking outside of the traditional NHS, but thinking about how do we define health? So we talk about population health management. What is our population? And critically, what is our definition locally of health? Are we just focusing on health care, or actually are we taking the broader definition of health, and how do we align all of our resources to improve the health and well-being of the local populations? Thanks, Deka.
Thank you. So lots more to talk about in this area, and everyone do keep continuing your conversation, so it sparks some thinking. But I've got one final question to ask our panel members. And also, Dan, a quick word about also, somebody talked earlier about this all seems perfect and a pretty picture, but actually, you know, what does it mean for me in my job? How do I do this for real? And if you could say a word about that, and then the question for everyone, what excites you most about the next steps for population health management, population health, internationally or across UK, and what's the single biggest opportunity that you foresee? So Dan, shall we start with you?
Thanks. So I would say do something, get started. No matter what your role is, you invariably have access to some data and probably more insight into your population than you're aware of. You may be privileged enough to be able to work with your population in a one-to-one direct basis. Ask those questions. Try to understand what it's like to be a member of your population or your community, and then try and start somewhere. Speak to your commissioners, speak to your colleagues, start to build momentum. And as I mentioned before, when you start to build that momentum, then you start making progress. And I would say that the Population Health Management Development Programme that's being run by NHS EI is spreading across the country. So by all means, get involved. Almost every ICS, every area will have the opportunity to have a bit of headspace to play with these ideas, and hopefully it'll result in a cultural change and much improved care for our populations.
Thank you. Anna, let's get a quick thought from you as well.
About the two questions, Durka, so next steps and...
Or just, so what excites you the most about, the next steps, and what's the biggest opportunity that you see?
I think the thing that really excites me is that I'm no longer being asked, why should we do this? I'm being asked, how can we do this better? I think we've made some significant progress in making the case for this, and it is quite an abstract thing. It's jolly hard to get your head round, but actually once people start doing a little bit, as Dan has just said, you don't need hundreds of data sets, you don't need 100,000 rows of data. Little bits of data in the context of a multidisciplinary team can make an enormous difference, and I think we've sort of made that case now. For me, the opportunities, coming back to a theme we've talked about already, are about inequalities. And I see that working in two ways. Everyone's probably familiar with the concept of big data, and we might be talking about cohorts, and we might be talking about strategic interventions. I also talk quite a lot about the importance of tiny data, and that's, it might be one child or one family or one person who is persistently homeless. And the complexities that sit behind all of those are very real and very difficult to crack, and no one agency can get really a good understanding of that without working in partnership with everybody else. And the data, it's not the only way by any manner of means, but it is a really important way of unpicking some of that, I think, and I think those are our opportunities going forward. Thanks.
Brilliant, thank you. Edward and then Don.
Thanks, Decca. I think we all agree that COVID-19 exacerbated the poor health outcomes that we have known for quite some time, and played in front of our very eyes, and accelerated the poor outcomes that perhaps were hidden behind by either time or by different contexts. So we did see the health inequalities playing out in the mortality figures. We saw that playing out in hospital admissions, and we will continue to see that playing out in the socio-economic impact and the legacy of COVID-19. However, I think it also gave us the opportunity for us to really come together locally and nationally to have a common purpose and to have a sense of urgency, and actually to build on the will to really protect people as much as we can. So I think we have demonstrated that where we come together for a common purpose with the idea of protecting our populations and improving the public's health, this can be done. We managed to progress some of the IG requirements within a couple of weeks that would have taken us months, if not years. So I think let's build on that. Let's not reset the system to where we were before, but actually let's build on all the successes that have been done within each local area, and let's build on that to deal with what is a crisis and what is an urgent issue around health inequalities within our local areas. Let's build on the momentum we have gained out of the COVID-19 and use that and the experience to tackle some of the wicked public health challenges that we have known and have rehearsed for many times. So thanks, Decca. I think for me, I'm excited on how we take this forward to improve the population's health.
Lovely, thank you. Don.
I share everything my co-panelists just said. I'm very excited by the move toward integrated systems in the English National Health Service. I think this is an authentic move, and it's got tremendous promise. Even more so if you remain together and learn together, as Edward was implying. You know more together than you use separately. If you take the idea that the integrated systems that are developing throughout the UK will remain together and be a learning set and actually exchanging models, you're going to double, triple, quadruple your speed of progress. So stay together, just like Edward said. My worry, it's the international version of the same. This has been a period pre-COVID when too many countries, yours and mine among them, were closing their doors and seeing themselves somewhat isolated. Brexit in your case, bad policy in mine, but that's happened. It's a worldwide phenomenon. That's not going to work. It's one planet, one world, one humanity. COVID's teaching us that, of course, but COVID or non-COVID, we're going to be better together than we are separately. And that especially applies, of course, to countries, nations of low and middle income who need to be part of the action. And I hope we remain far more generous and connected than we ever have been before, instead of isolating ourselves. We'll see how that goes.
Thank you. And I think on that really important note, I'm going to thank our panel and leave that with us as something to keep us going, keep us together, keep working on this. Thank you for all your fabulous contributions. I know we're running a tiny bit late. Apologies for that. I'm going to hand over now to my colleague David Burke and Jackie White to bring today to a close.
Thank you, Durka. Thank you to the panel, and thank you to the audience too for being so engaged today. It's our job to send you home and just say a few reflections. So, but one thing I want you to do first is to actually do more action. So, if you wouldn't mind just using Slido just to answer the question, actually not to answer a question, to make some pledges, because I think this is really critical. The things from you've heard today. And everything you've thought about and reflected on, what you will do in your role to help better deliver population health. If you want to put that on the hashtags that we're using today, do so as well, because this is really about sharing and supporting each other. So that's my one ask of you today. I'm going to hand over to Jackie, who will just say a few words towards the end before we let you go. But I just want to say, one, I will reflect a few reflections on some of the things we've heard today. That will obviously not cover everything, and I'll miss lots of things. But two quick things. One is the King's Fund is really committed to population health. I hope you've seen that. And we're really pleased to be working with NHS England and NHS Improvement on this. They have made this possible today. So we will be continuing in this space on this journey with you. And if we can help you in any way, please get in touch. Today's session will be on the platform that you've been using today for the next couple of months. So you can come back, reflect more, look at sessions that you've perhaps missed, and then it will be transferring to YouTube and it'll be there in perpetuity. So you haven't lost anything of this today. Some very quick reflections for me. I think we started off talking about the challenge of COVID, its long shadow, inequalities, the challenge of digital inclusion, hidden need, hidden harms. And I think then moved very much into the role of population health management and data for actually understanding that, the shape of that. But I think as we've moved through the day, I think what I've seen are a couple of things. One is about the fact that data is a starting point, and actually it helps us understand what's going on. The critical thing is that connection back into communities and into people and into reality. So the data and population is an incredible tool, and we need to use that and connect the data across people, across sectors. But that's the starting point. That is the way that we can then move on to better action. And I think a phrase that came out of that early conversation, the term someone used, democratic data. We need to make all that information as free and easily used and shared and analysed as possible, and be very open about that. For me, population health management is glue. It can help bring together and help us focus more on inclusion, on partnership. We've had some fantastic, I'm really pleased that we've talked about the NHS, but we've talked about so many other sectors too, including the voluntary community sector, councils, district councils, who are often left off the list when we think about things, some really powerful role district councils, housing, all police, but critically communities themselves. And so I think PHM, when used well, when interpreted well, can be the glue that sticks a lot of this stuff together, and also helps us bring together the insights and the critical insights of both the medical and social models of health. It's not one or the other, it's both. And then before I hand over to Jackie, just quickly another phrase that I thought was really interesting about ICS. And I think it was Sakti, again, who talked about ICS standing for Intelligent Conscious Systems as much as it is integrated care systems. And I think that combination of the structures and that intelligent, conscious thinking about the information, data and knowledge that we have, both informal and informal, leads us in the direction of true population health systems. So I think we're all on a journey, and I hope that you've enjoyed listening and sharing, and you'll reflect more on that journey in your own places, systems, as we go forward. And finally, I think it's really fantastic that we've had international speakers and insight, both to challenge us, but also to say you're doing well, keep going, and the world is looking to us, and we must look more to the world as we move forward. So thank you very much for joining us, and handing over to Jackie just to say a few words so that we can all go home. Thank you.
Thanks, Dave. I think going home has a different connotation these days. Brilliant summary of what has been a fantastic day. Great discussions, great presentations, fantastic questions. So thank you. Just really wanted to echo the point that this is a team sport. No one person, no one team, no one organisation is going to solve these really crunchy problems on their own, and that we need to keep true to the purpose of integrated care systems to really drive that focus on population health and addressing health inequalities, and those systems enabling partners within local places and within neighbourhoods to really think about what matters most to local communities. I really just wanted to finish by reminding people there are lots of great resources that have been shared both in the platform for today. If people aren't already registered, we have a PHM Academy, which is a great way to keep up to date with latest guidance, case studies, webinars, and a very active virtual network. I'd be really keen to look at how we can continue to build that to be as useful as possible. And then finally, just wanted to go back to the start and what I mentioned right at the beginning, which was that our aim today was to bring together a community of people from across the world who are as passionate about this as we are, with the aim of sharing progress, discussing challenges and stimulating action, but also to create that ongoing global network that enables us all to learn and improve together. And I hope that we've made a start today, but again, it would be great to hear from you how we can capitalise on this going forwards. So thank you very much to everybody who's been involved. Thank you to the King's Fund for putting this on for us. And I hope that it's been a really interesting and informative day for everybody.